much, Dr. Lutfi. So we are going to listen to the next presentation, which is from Professor Dr. Aizura Adlan, who is one of our senior staff in the department and also a certified trainer for minimally invasive gynecology for the Ministry of Health and Ministry of Higher Education. So she's going to talk on the hysteroscopy, out office hysteroscopy. So let's listen to her presentation. Over to you, Prof. Aizura.
Thank you, Prof. Mukhri. I will share my screen now. Okay, thank you very much. Thank you for this platform. It's been quite some time since the last breakfast at UMHealth for me. So today we will be talking about scope and go. As much as we have our coffee and go, we have our breakfast and go. We are trying to introduce a new service, what we call scope and go, the office hysteroscopy at UMHealth. So primarily the issues here will be endometrial polyps, where we know that it is common in women with abnormal uterine bleeding. Usually they will come with complaints of bleeding in between menstruation, or they can come after menopause and they have this sudden bleeding, or even just unexpected bleeding or unpredictable bleeding. And there are also cases where they come from the infertility or the subfertility patients. They present and they, in the reproductive clinic, you do an ultrasound and then you find, oh, okay, there might be something there. Risk of malignancy is actually very low, although present, and the gold standard of it is usually a hysteroscopic polypectomy. Let's be very honest, okay? What is a hysteroscopy in the first place? So technically what it is actually a long thin tube which goes in through your vagina, or the patient's vagina, into the internal os to shine and look into if there are any problems within the intrauterine cavity. So why this procedure needs to be done, it is considered as a minor procedure, okay? But why are the minor cases still filling up our OTs, okay? So this can take away the burden of actually waiting for weeks, waiting for an operating time for a 10-minute scope, you see? Look at this girl. She may have had a fungal infection only on her forehead and now it has gone all over her body, just because she has to wait for a long, long time. So the polyps are usually small. And, to actually undergo either a spinal or a general anesthesia for a 1.5 centimeter polyp sounds like a big deal. So at minimally invasive gynecological surgery, we say no more. Let's do something about it. Let's let's improvise the situation and what can we do for our patients. So why office hysteroscopy? Obviously, it is efficient and cost effective. You reduce hospital stay, you also reduce associated costs. Quick recovery immediately after the procedure. Patient can be discharged. It does not even need in-ward management. Patient is comfortable. You avoid general anesthesia. They prefer the familiar setting because it's an office setup. And of course, studies have shown a higher satisfaction rate. So the idea is spot them, scope them, solve them. Okay, so that is the idea here of our endometrial polyps. We can scope today, and office hysteroscopy will redefine intrauterine care. So you walk in, scope, and you walk out. So no GA, no OT time. Right, so this is of course for my trainees, okay? You need to get the right candidates, of course, right? They must be hemodynamically stable, cooperative. When you do an ultrasound scan, you see that the polyps are less than 2 centimeters, and there is no suspicion of maybe a deep myometrial invasion. But if you see that patient has got a severe cervical stenosis or a large, broad, sessile lesion, or you can estimate and gauge that the patient may have a low pain threshold, then probably they are not the best patients for that matter. In fact, you can also screen this if they come to you from primary care medicine. Okay, so you might be the first line to see such patients and you can then refer them to us. Pre-procedure preparation. So it's quite it is quite organized. Okay, the counseling happens. You set expectations, discuss the pain management, what can be done, informed consent. Any procedure we do, we know that there is always a risk of complication. There is a risk of perforation. Okay, and we need them to understand this. Okay, pain reliefs are given about 1 hour before. If the cervix needs to be primed and or softened, and it may be done so. We do perform a cervical block so that they do not feel any pain. That is being done. And of course, timing is gold. If we can schedule it, in an early proliferative phase where the lining is thin, that's perfect. But I think most of all, it's like the patient is happy if it is of the same day convenience. So that's very happy for them. They come in, they get that checked, get it done, and then they go back home. Of course, a calm and supportive staff environment. So this is our setup on the 4th floor of KWKK. And this was actually, I think, our first patient that we did. Yes, okay. Okay, so equipment is very simple. We've got a rigid scope, we've got flexible scopes. They're about 19 French or 15 French, it converts at about 6 millimeter, 5 millimeter or so. Only need normal saline for distension media. And you have, these, the shaver, and also the graspers and scissors. Okay, so let's see. Let me just show you while I speak. Let's just play you some videos. So what you can see here are the polyps. Okay, so you're now inside the endometrial cavity, and we see that the shaver is now taking action. So you've got a nice round polyp there, and it's shaving it like a Pac-Man effect, chomp, chomp, chomp. So if patients are very scared, you can even attempt with a vaginoscopy, which means that you don't even have to dilate, open up the cervix. Preferably, of course, if we can give a cervical block, that would be even better. Distension pressure is about 80 to 100 millimeters mercury. That gives us a very optimal cavity visualization. And of course, field clarity due to the continuous flow, that can also prevent the bubbles and debris accumulation. All right, but we tend not to go beyond patient's mean arterial pressure. Precision without admission. So got the pain management, the paracervical block is there. That's the cartoon. You can see that the cervical anesthesia, the block is being given at those areas, 10, 2, 8, and 4. Bleeding is actually very minimal and quite self-limiting. With gentle technique, and since you avoid blind traction because you're going in carefully into the tunnel, you can avoid perforation. And prophylactic antibiotics is actually not routine. And the benefit of it is that we can now get all this tissue dissected and analyzed, set for histopathological examination. So it's mechanical, yes. If it is very small, then what we need to do is just to go in, grasp it, and get it out. But if it is larger, like for example in this video, we can see that you can perform a shaving. So here we use a Bugatti shaver. It is a reusable mechanical shaver, simultaneously cutting, and it sucks it out. So that gives us the benefit of maintaining a clear field, and it is also energy free because we don't use any thermal energy. So less pain, no smoke, and no burning. How do we optimize this procedure? All right, this is also for my trainees. Begin at the polyp base. Now, you've got to maintain consistent orientation throughout the procedure. You're in a hole, you're in a tunnel, so you're looking, so you're 12 o'clock, 6 o'clock, 3, 9, and take your time. Slow, deliberate movements. So always, post-procedure, reassess the cavity, post-resection to ensure that you've done a good job, complete job. Okay, so you can see that the procedure actually does not take more than 5 to 10 minutes, in fact, if you can get it done. And the benefit is that, and if you have patients out there seeking for reproductive assistance, it does improve clinical pregnancy after you remove the polypectomy. Once the polypectomy is done, it does support, especially interventions in unexplained infertility issues. Okay, so when there is a procedure, of course, we should provide what kind of troubleshootings are there. If you see that the visualization is poor, you'll have to check the fluid flow, remove the bubbles. You can see from the video that there are also some bubbles there, and of course, clean the lens. If there is a cervical resistance, of course, you've got to prime the cervix, perhaps even use a smaller sheath. So now there is the availability of the 15 French shaver, although it does tend to be a little bit more pliable. Importantly, if you suspect that there are some vasovagal episodes, stop, pause, okay, elevate the legs, reassure, and if it is too big, you can always do a second look, incomplete if the resection is incomplete. You can always do a second attempt, or if necessary, you can always reattempt that under general anesthesia. Patient aftercare. So we tend to tell the patients, okay, after the procedure, you might have a little bit of spotting, but the resumption of normal activities is actually quite immediately. They can drive back home. Someone asked me about post-procedure cramps. In actual fact, our patients do quite well. And we usually bring them back to the clinic about 2 weeks later for the histopathological examination results. And we will reevaluate if the symptoms recur or persist. So OT safe, patient satisfied, patient is happy, and with the proper selection, proper techniques, appropriate instruments, continuous evaluation, and keep the best practices, I think we can be the next referral center for such things. Because at the moment in Malaysia, the Bugatti shaver is not being used as an outpatient hysteroscopy procedure anywhere. A lot of the other hospitals are doing it in the operating theaters only. So the future is not the future is now. Now we want to try and do even smaller scopes with from 19 French to 15 French. People are looking into AI for real-time pathology assessment. You can actually now put in a scope and see, and you already know what is the pathology. It's fantastic. And of course, personally, of course, we are hoping for an outpatient expansion. People understand that we are the place, we are the go-to people to do this at a referral point. And of course, always trying to aspire for training, and we have to work on this training and credentialing under minimally invasive gynecological surgery. So that's our first patient that we had. And it's always about precision, of course. And precision is not about the speed, but it's about control, I must say. We're not just embracing change, we want to lead the change. That is the mantra, at least for us. And the future is walking, not wielding. So that's actually the end of the talk, that we can have a lot more time to discuss the issue. That was in 2014, and that is Giuseppe Bigatti himself. And we introduced it in 2014, but we actually managed to buy it only in 2024. And I must say, thank you very much, Prof. Nazira, for allowing that to happen through the UMMC. Thank you very, very much. And yeah, you can see some of our medical students have also seen him, and we're very happy, to be discussing things with him. Thank you.
Thank you very much, Prof. Aizura, for a very nice, beautiful lecture on having a hysteroscopy, operative hysteroscopy done as an outpatient. So we are now open for any question and answer. This before we go for the question. So maybe Prof. Aizura can let them know any pain relief given because it's not under GA, right? So any pain relief given for this patient so that the audience know that it's still some medication that we give.
I think I've also mentioned it there. We do give paracetamol and Celebrex, celecoxib, 1 hour prior to procedure. We do that.
Okay. So we got one question, of course, from Professor Tengku Sarah, and he said that how many have you done in PPM, and are you also doing it in UMSC?
We have been doing this since what was it, the beginning of the year? I think we closed about 10 cases now or so. We're still trying to pick up cases. We had to sort out the logistics of patient having it done, being seen in clinic, bring them upstairs, and then get them done. Am I also doing this in UMSC? with difficulty because the procedure is not available in UMSC. So we actually have to take them, bring them to UMMC, get them registered, get that sorted out. Yeah, so that's that. How is the patient satisfaction
Mhm.
rate so far? I would say good. And the
Yeah.
symptoms,
Mm.
yeah, we've had very successful results. We bring them back, we monitor them very closely, even though we discharge them. And so far they're okay. So yeah, we do need extra cases. We do need more. So I'm using this platform as well to get more cases and more cases referred to us.
Okay, yep. If you have more question, please put it in the Q&A or so that I can moderate it. So maybe Prof. Aizura can let them know that the outpatient cystoscopy has been done before this, but the one that we presented is the operative cystoscopy because the diagnostic one has been done maybe since the inception of the KKWK. So it's not new for the new outpatient diagnostic cystoscopy, but Prof. Aizura is telling us about the operative
Yeah.
cystoscopy, right? Professor?
Right. We have been doing diagnostic hysteroscopy for quite some time now, since the inception of KWKK, which is 2011, in fact. Uh, but that is only for diagnosis. So we need to diagnose it and then we decide what to do and then we plan for something. But now we have the ability to diagnose it and treat it if possible. And then patient can be discharged. So that's the benefit of it. So I thank you, the department, for actually bringing back.
So it's an operative cystoscopy. The diagnostic has been done many years already by Medios, but this is the operative cystoscopy that we are informing you all now. So there's one question: what is the cost of receiving office cystoscopy at UMMC?
660 ringgit. Because
So
the
there are
consumables, yeah, the consumables are the pipings and the wires. The shaver itself is actually reusable, so that's sorted out. That's why we opted for this because it's reusable. In the private, the cost of the whole procedure itself may come to about 2,000 ringgit. So in UMMC, the cost is 660 ringgit, I think. Yeah.
Mhm. Okay, so therefore, in the daycare procedure, you actually avoid paying for the admissions and OT time. So it's actually quite good to have it as a daycare. Yep, and the shaver is reusable, so reusable, but it will be blunt over time. So there is some certain number of cases that we can do for the thing. So we need to buy a new one. But of course, the consumable is already factored in the costs that we micro costing for it. Um, how about uterine fibroid, Prof. Aizura? Is it only for polyps or is it for uterine fibroid or septum for this
Um,
operative cystoscopy?
Very good question. Yes, it's also for fibroids, but we tend to do only fibroids less than 2 centimeters or not more than 3 centimeters because we have seen that when you do 3 centimeters, it takes a longer time. And sometimes fibroids are also harder. So the shaver will consume too much of time. A resectoscope would be better with thermal energy, and that can be done in the operating theatre. So patient selection is imperative. We have to be very selective with our patients as well.
Okay, so yep, that's correct. I mean, that's what we want everyone to know. That is mainly for polyp, but for uterine fibroid, it reduces the efficacy and also blunt the blade easily. So there's not one more question here. Is training for OP cystoscopy currently available for trainees in UMMC and how to enroll?
Mukhri, you want to take that? Okay, yeah.
So, yes, of course, all our trainees are accessible to the scope. So if Prof. Aizura is doing it, they can actually come together. But for the training, yes, of course, we are doing the subspecialty training for minimally invasive. So it's maybe part of the module. So I think it's going to be available soon because we are writing it for the subspecialty. And now Prof. Aizura is one of the recognized trainer for the national minimally invasive, not only histoscopy, for laparoscopy. So I think it's good to highlight that we are one of the centers for the training. And the next one is do the histopathology results for the 10 plus UMMC patient, who the patient that we did who underwent endometrial sampling during office cystoscopy indicate only endometrial polyps.
No, there are some fibroids as well, some small fibroids as well.
Okay. Yep.
Office, yeah, correct.
Because we tend to do fibroid using resectoscope, right, Professor? Just we spare it for polyps, but of course, very difficult to look on ultrasound and via the scope whether it's fibroid or polyps. But if it's already there, we just do it. But of course, we don't do it for fibroid because it's too hard. It's quite hard. I mean, the consistency. It's not the difficulty of
Yeah.
the procedure. Okay. Okay, so we still have 10 more minutes. Maybe a few last word from Prof. Aizura before we close. Or if you still have a question, we can answer that. So any last word from you, Prof. Aizura, regarding this
I hope
procedures?
the procedure is Prof. Yang Farida has asked something. Prof. Yang is asking something.
Yes, how many percent are realignment or malignant?
How many percent are realignment or
Prof. Aizura?
malignant? Alhamdulillah, actually, because we're very selective of our
It's in
cases.
the chat.
In the chat
So
box.
how many percent are realignment or malignant?
Pre-malignant, I think.
In the
Pre-malignant.
chat box, it's not in the Q&A.
Correct.
Oh, pre-malignant.
Malignant, yeah. So far, Alhamdulillah, all our cases are not malignant. That's why patient selection is very, very important. We have to assess and see and feel that, yes, this is a benign situation. In the operating theatre, we've only gotten one case where it was malignant, and that also was not to clean it up, but it was only to see, and then subsequently the whole thing was avulsed and removed. And then we proceeded with total abdominal hysterectomy. But Alhamdulillah, at the moment, all our cases that we have done have been benign.
Any other questions? Okay, thank you, Prof, for the good work. So that's Prof Yang remarks. So maybe one last word from you, Professor.
No, I talk too much and I never have last words. So I think thank you very much for the
Okay.
opportunity. Yeah, thank you for the opportunity and for us to talk to everyone to introduce this new, not new lah, not really new, but this service. And so we hope that maybe we can get more referrals and the outreach from outside to come in. And yes, anybody and everybody within the ONG fraternity, of course, is invited to train. In fact, my team members, they are always training on site, and they do it themselves with my supervision as well. So training happens all the time. Thank you, Prof.
Okay, thank you very much. If there is no more question, and I think we can finish or close this breakfast at UMHealth for this session. And I hope that you enjoyed the two talks that we had today, and hopefully that we get more referrals from you if you have any. And that's all for today. Thank you very much.
Thank you very much. Assalamualaikum.